Hi. So the purpose of this talk is to try to help improve our sensitivity and maybe even optimize our sensitivity and the ability to detect neuro-ophthalmic manifestations of pituitary or Sellar tumors. So when we have patients who have ophthalmologic manifestations, the symptoms will be either complaints of blurred vision in one way or another. Maybe it's their central vision, it's their visual field. Might be in one eye or in both eyes. Or they might be actually experiencing diplopia because of the manifestations on the cavernous sinus. In terms of signs, what we could detect on our ophthalmologic examination, we might find that there's actual reduced visual acuity, or the visual acuity can be perfectly normal, but there can be visual field defects. We're going to talk a little bit about the use of OCT, an extraordinary tool to detect first manifestations of chiasmopathy, for example, or an optic neuropathy. And finally, how to ensure that we're detecting any sort of slight strabismus that might be there, even when the patient isn't complaining of double vision. And this brings me to the point that sometimes, and not infrequently, I encounter patients that are asymptomatic and yet they have clear neuro-ophthalmologic manifestations that are just subtle. And so that becomes the main challenge. How do we make sure that we identify these cases as well? So just to take perhaps a typical case, it's maybe a bit hypothetical, but a 50-year-old woman who maybe has headaches, and she's undergone neuroimaging for the headaches, and there's findings of a meningioma in the Sellar zone, maybe a tuberculum cella meningioma. And according to the report and according to the review of the MRI, there's questionable compression on the optic apparatus, there's questionable extension into the cavernous sinus. She herself has no complaints, and now the neurosurgeon obviously has to make a management decision to go ahead and resect, to irradiate, just to simply observe. And so here, again, our goal is that even if she's not complaining of anything, how do we really verify that? And that's the sort of situation that I'd really like to address here. So the tools that need to be used to assess this question, in addition to just a basic ophthalmology examination, are doing a visual field test, looking at OCT, and strabismus testing. So in terms of visual fields, so we are probably intimately familiar with this as the manifestation that we maybe expect in a chiasmopathy, a bitemporal hemianopia. This is the classic situation, but it's probably uncommon to have just this pure, complete bitemporal hemianopia. And if this is all that we're looking for on our radar, then we're going to miss other manifestations. This is a more common sort of scenario where we have a bitemporal hemianopia, but it's located only in the superior zones of the visual field, and that's more consistent with the story that would happen from a pituitary adenoma. And I'll just remind you that if we think about why a pituitary adenoma would cause a superior visual field defect, so we need to remember that everything's inverted in our retina. Images that come from above will be stimulating the inferior part of the retina, and those images will be transferred to the brain along the inferior portions of the optic nerve, the inferior portions of the chiasm, and the inferior portions of the optic tract. And so when there's a pituitary that's compressing on the chiasm, it's going to compress on those inferior fibers that are responsible for detecting what's coming from above in our visual fields, generating this sort of pattern. We need to be aware that in the first stage of manifestation, this hemianopia might just be in one eye, and it might just be in the extreme superior zone. This is the place that's going to be affected first during the first stage of compression. Again, we might see it in both eyes, we might see it in one eye. And so just having this superior defect that's temporal and respects the vertical midline becomes concerning and something that an ophthalmologist or a neurosurgeon needs to pay attention to, and at the very least repeat the visual field study to see if this is a reproducible phenomena. So here I want to draw your attention to something else, and that's that in our classic situation, we have a pituitary adenoma that's going to be compressing on the chiasm itself. But there's variations of how the anatomy of the optic nerve's chiasm and tracts are configured. Here's an example where the pituitary gland is situated rather anteriorly, and the chiasm is situated posterior. And so if this pituitary develops into an adenoma, the compression is not going to be on the chiasm, it's going to be on one or both of the optic nerves. And again, if we're just naively looking just for chiasmal effects, then we're going to miss these sorts of scenarios. The opposite situation can also occur where the chiasm is pre-fixated relative to the pituitary. And in this sort of case, the growth of the adenoma is going to manifest itself on compression of the optic tract. And so it's extremely important for us to be attentive to the fact that there are going to be variations of visual field abnormalities. We can have visual field defects from chiasmal compression, and that might be the classic full bitemporal hemianopia, but it might also be partial. And that partial variant, it might be superior because it's a pituitary adenoma. It could be an inferior bitemporal hemianopia because of superior compression from a craniopharyngioma, and it might be in one eye or in both eyes. And then if we have a situation where the pituitary is compressing the optic nerves, then we're going to get compression there, or visual field defects in one or both eyes that are more representative of just an optic neuropathy. And if it's compressing on the optic tracts, we can get homonymous hemianopia that again can be total or partial. And so this is where it is so critical to have good radiological correlation. And thankfully, I was trained to be able to look at the MRI itself and to try to predict where do we see contact between the tumor and the optic apparatus, and then to understand how it should relate to my clinical examination. What am I anticipating to find? Am I anticipating to find optic tract compression? Am I anticipating to find chiasmal compression that might be more displaced to the right or to the left? And I think that this is very critical in these sorts of scenarios. OCT is an amazing tool that has really revolutionized ophthalmology and is extremely relevant to these situations. So OCT stands for optical coherence tomography. This is basically the MRI of the eye, except that it probably has much higher resolution than modern day MRI, almost to the level of being able to see cells. And that allows us to perform high resolution imaging of ocular tissues for the retina, for example, and for our scenario for the structures that are related to the optic nerve, and that would be the retinal ganglion cells in the retina and the retinal nerve fiber layer. These are the structures that form the optic nerve. And so, as we all know, if the optic nerve is being compressed, that's going to cause atrophy. And it's going to cause not just gross atrophy that could be seen on maybe an MRI, for example, but on OCT, we're going to see atrophy of those related tissues, such as the retinal nerve fiber layer and retinal ganglion cells. And the amazing thing is that sometimes these changes can often precede the changes that we can detect in the visual fields. And that's why OCT is such a sensitive tool for detecting any sort of issues with the optic nerves, chiasm, or tract, since they're all part of the same neuron. The final component that needs to be carefully analyzed in these situations is looking for a strabismus. And again, I want to point out the fact that patients can sometimes be asymptomatic that they have a strabismus because the cranial nerve affected, if only affected slightly, may only cause a strabismus to manifest when they're looking in some extreme direction that they typically don't use. This is why it's so important to assess whether there's any evidence of a strabismus in any direction of gaze. And the way that I think is easiest to do that is just give the patient a target to look at the other end of the room. And then while they're looking at that, you ask them, do they see double or blurry vision? We'll get to that point in a moment as they're looking straight ahead. and then turning their head to their right. If I'm looking at the target with my head turned to my right now, I'm really testing my left sixth nerve. Turning to the left, vice versa, with the head up and the head down, looking at that same target, and that would test if there was a third nerve palsy, for example, and with my head tilted to the right or to the left shoulder to detect the slightest evidence of a superior oblique palsy. And not infrequently in my clinic, I'll have a patient who all of a sudden says, oh my goodness, when my head's tilted like this, I'm suddenly seeing double, and that obviously clues me into the fact that they do have manifestations, maybe in this case of a left superior oblique palsy. The other thing that's extremely important to remember is that in a slight case of strabismus, the patient might not report that they see double, but just that they see blurry. And that's because the images are still overlapping. They haven't been separated to become discrete images. And so even a patient reporting that their vision is blurry, particularly in a particular direction, can be a sign that there's a strabismus there that needs to be further explored. So the goal of our lecture was how we can detect even the subtlest first signs of neuroophthalmic manifestations of pituitary or Sellar tumors. And I hope that I've succeeded in showing how visual fields and OCT and careful strabismus testing can be essential in terms of making sure that we're not overlooking something subtle when we're doing these sorts of assessments. For further information about a lot of these topics, I have lectures on YouTube, and I encourage you to please explore them if you think it's helpful. And if you have any sorts of questions, please feel free to be in touch with me. Thank you very much for your attention, and good luck.